Okay, so I'm going to go ahead and launch. Once again, this is Christine Toriason from FHI 360 in North Carolina. Welcome to the PrEP Learning Network. This is a global virtual learning network around oral PrEP. And today we are talking about going virtual with PrEP service delivery. Next slide, please. And we have a very full list of presentations today, and we are going to go for an hour and a half because we want to have sufficient time to talk about these important initiatives as well as answer questions. So today we're going to talk particularly about how can we leverage virtual platforms in the time of COVID-19 to continue to serve our PrEP clients. And so we're going to hear overview on PrEP in the time of COVID-19 and how to leverage virtual platforms. We're going to hear from the Vietnam PrEP Plus team on their online consultation and courier service. We're going to hear from Three Dreams Go Digital, adapting PrEP delivery for adolescent girls and young women in Kenya. And then we're going to, those three presentations are from the PATH team, and then we're going to hear from the EPIC team about going virtual with PrEP service delivery in Eswatini, and also PrEP Telehealth and Express services in Thailand. So let's go on to the next slide. These are our speakers. We have Kim Green, who's the Global Director for HIV and TB and PATH, and somebody just drew on there, but it's gone. So Kim has more than 20 years of experience focused on health service delivery innovations. She's a lay provider and community-led she's a lay provider and has done community-led healthcare, developed tools and approaches that optimize self-care, and you can see the rest of her bio there. We also welcome Na No, who's a senior clinical officer with USAID PATH Healthy Markets. She's a medical doctor and clinical health specialist in Vietnam, and she leads implementation of the project's continuous quality improvement and quality assurance initiatives, as well as efforts to develop, introduce, and scale new models for the delivery of HIV prevention, testing, and treatment. Next slide. We have Tom Tran, who's a senior marketing and communications manager also with the PATH Healthy Markets program. And Tom has over 10 years of professional experience in marketing, communications, and project management, and she currently leads the development and implementation of marketing and communication strategies on HIV goods and services. We have Madian Daniel with us, who is the technical advisor for adolescent girls and young women with PATH in Kenya. And Madian has 20 years of experience providing technical expertise in social and behavior change communication across many different areas, including HIV, TB, malaria, gender, and sexual and reproductive health. Next slide. We welcome Ben Eveslage, who's a technical advisor for online HIV services at FHI 360, part of the EPIC project. Ben is a technical advisor. As I mentioned, he leads a portfolio called Going Online, which helps global and bilateral HIV programs use online and mobile platforms for HIV outreach and service delivery. Laura Muzard is also with EPIC and Linkages program in Eswatini. She's a project director, and she has over 15 years of experience with USAID, PEPFAR, and UNICEF funded projects across multiple continents, and she's been our FHI 360 country office lead for the last 5 years. Next slide, please. And finally, we welcome Tanat Chinbunchorn, who's the technical support manager and a research physician at the Thai Red Cross AIDS Research Center. And Dr. Tanat focuses primarily on implementation science research with key population-led health services, HIV treatment and prevention, and PrEP. So those are our speakers today. As I've mentioned before, we have a chat feature. Unfortunately, it's preset to all panelists, so I ask you to manually go in and click the little arrow that allows you to select all panelists and attendees, and that allows your colleagues to see your questions and chat. Next slide, please. So I just wanted to do a quick framing of why PrEP delivery must go on in the context of COVID-19, which I think all of you are probably already very much embraced this concept that, you know, despite the shutdowns and all the attention that is focused on COVID-19, HIV risk is ongoing. And in fact, there are additional risks that are associated with what we see now as some increased gender-based violence, job loss, and homelessness that is occurring during this pandemic. In addition, the demand for PrEP continues. Most of the country teams that we talk with report that they continue to have folks seeking PrEP and wanting to continue on PrEP. And so really, in some ways, COVID-19 presents an opportunity for us to move PrEP out of the biomedical sphere, where we know that we have had many challenges with stigma and access, and move it into a more creative and diverse delivery model that includes virtual modes that hopefully will make it easier for people to access PrEP. And we hope that even as this is a challenging time, that ultimately this will actually move things forward in a positive direction for oral PrEP delivery. Next slide. I also just wanted to do a little refresh on the PEPFAR guidance on PrEP in the time of COVID-19. This is from the May 22nd PEPFAR guidance, and they send out this guidance on a regular basis. Just a reminder that PEPFAR has provided guidance that PrEP is an essential component of PEPFAR HIV programming, even in the context of COVID-19. That strong advocacy for PrEP service delivery should continue as part of comprehensive combination prevention. That PEPFAR recommends moving PrEP services away from and out of the clinics as much as possible, using virtual options and decentralizing dispensing of PrEP and moving to multi-month dispensing as much as possible. Furthermore, this has been a frequent question, but the decision on whether multiple months of PrEP can be given on the first or initiation visit needs to be made on an individual basis based on an assessment between the client and provider according to the client's needs. So with that background, I'm going to move on to our first speaker, continue, and pass this over to Kim.
Great. Thanks so much, Christine. So my colleagues and I will be presenting on PrEP in the time of COVID-19, leveraging virtual platforms for telehealth and home delivery systems for PrEP ARVs and diagnostics to ensure continuity of care. Next slide. So I wanted to first start with sharing an effort that's being led by the International AIDS Society's Differentiated Service Delivery Initiative, AVAC, and PATH, to seek examples of community-based differentiated PrEP service models. So we've long known that facility-based PrEP alone may not meet everyone's needs, and to that end, we're wanting to document learning from less clinical models and those that enable greater choice in response to client preferences. So we've had 50 complete submissions thus far, and 7 feature different elements of virtual PrEP service engagements, including the 4 presentations that you'll be hearing today. So if you've not already submitted and have an example to share, we'd welcome your submission. There's also a link here to an article on differentiated PrEP. Next slide. So now turning to COVID-19 safe PrEP considerations for virtual and in-person contact, since there may be a blend of both. And these are further amplifying what Christine shared based on PEPFAR guidance. So first of all, we know it's important to determine how best to communicate with clients during COVID-19 lockdown. So whether for PrEP new enrollment or continuing enrollment, whether or not virtual is possible, or if not, in-person is needed, as well as time for follow-up. And if virtual, then what tools are feasible and preferred? For example, phone, WhatsApp, video chat, and also with consideration of confidentiality and personal safety, which are paramount. The second has to do with talking with clients about what to expect with virtual engagement. So this might be new for many clients. And so it's important to frame what will be covered in a new PrEP enrollment or in a PrEP continuation check-in. Second, there's a number of different experimentation right now with home-based specimen collection. During lockdowns, you'll hear of some programs that are offering blood-based HIV self-test kits that are being delivered or mailed, where lay provider or healthcare visits are not possible, and you'll hear about that from the Vietnam team. There's also safe home specimen collection by mobile lab services or by healthcare workers that are being offered in some countries. And then related to that is home delivery of PrEP ARVs. So looking where possible, what options might be available and what clients prefer. So for example, courier services like Grab, postal services, or drop-offs from peers. And you'll hear about that approach from the Kenya and Vietnam presenters. And then lastly, we know that some facility contact may be required. And so, focusing on all of those steps that are critical to ensure safe contact, pre-entry symptom screening, universal masking, and maintaining physical distancing. Next slide. So some further considerations for virtual new PrEP enrollment. As Christine mentioned, looking at options for multi-month dispensing for new enrollment is great if that is possible for the client and within the country context. So that minimizes the need for that return for that first month visit. Second, really looking at what information clients might need around side effects for new enrollment. So given that they may not be able to then contact a health facility directly, information that they can have available to them of who they can follow up with if they experience side effects, so they can secure support. And then also, we know that people are experiencing COVID-19 lockdowns in different ways. And it's important to talk with clients about whether or not they're continuing on PrEP as usual, want to pause on PrEP, want to restart. And for men who have sex with men, whether or not there may be the need to switch between daily oral or event-driven PrEP, and so forth. And then as well for adherence support. So for those that are newly starting and whose routines may have been disrupted by COVID-19, it's also important to have that conversation around what's the best way for that client in that context to remember to take their PrEP meds. And then lastly, STIs. So STIs are still a concern, and where testing is available, it's important to continue to enable those services. So you'll hear about a self-sampling model that's being implemented by the Thai Red Cross, which is really exciting, but also important to have safe visits to designated health services where that's possible. Next slide. So we also know that COVID-19 has increased intimate partner violence, mental health morbidities, substance use, and other difficulties for the clients that we serve. And so it's important, where possible, to consider hotlines or virtual or physically distant peer support and counseling services that can offer critical wraparound support to PrEP users. Next slide. So with that, I wanted to turn to the two sets of presenters. So first, the Vietnam team, Dr. Nga and Tham, who are going to present on Vietnam PrEP Plus, online consultation and courier service. And then we'll move to Dreams Goes Digital and the presentation from Mariang Daniel. So over to you, Nga and Tham.
Yeah, thank you, Kim. So next slide, please. Dr. Ngai and I will share experience of PrEP implementation in Vietnam during COVID-19. Yes, and in February 2017, the Vietnam Ministry of Health and USAID Healthy Market started PrEP program in Vietnam with a partnership approach between KP community-based organizations, CBO, and public-private clinics. A CBO paired with PrEP clinics to reach clients and assess for HIV risks and support for PrEP adherence and continuations. And today, we support 18 clinics in 3 HIV high-burden provinces and cities of Vietnam, including Hanoi, Ho Chi Minh City, and Dong Nai. And among 8 private PrEP clinics, 7 are owned and led by KP groups. The 10 remaining PrEP clinics are public ones. And to ensure that PrEP can best respond to client needs, CQI, continuous quality improvements, and community stewardship are one of our strong focus. Next slide, please. Next slide, yes. And a study of healthy market in 2015 found that the majority of KP community in Vietnam are online. They have a feature phone or smartphone and they use Facebook. MSM community uses several hookup apps like Grindr, Blue, and with PrEP service launch, we knew that knowledge level of community were low and effort are needed for intensive demand creation activities. And we work hard with community to create content and define complementary rich tools and create an online ecosystem to reach clients with PrEP information and link them into services. And as you can see on the screen, this includes an online HIV risk assessment, a platform to order HIV self-test kit, and an HIV service booking app that link clients to appointment with private clinics, while online peer influencers promote PrEP contents on various online platforms such as Facebook, hookup apps, and YouTube, Instagram, etc. And this is to build a normative cultures around PrEP use. And we use also chatbots, which answer typical questions such as what is a PrEP, what are its benefits, and where can I get it? And then link client to an online peer influencer and the service booking app. And most recently, we also set up a COVID-19 HIV hotline led by community influencers where people can go in. They can also ask questions about PrEP service, about HIV self-testing, and other HIV information that they need. Next slide. Yeah, so this one is just simply to show you one example of PrEP promotion on Blue dating app, very popular dating app for MSM in Vietnam. This one was before COVID-19. Next slide. And we can see here that the demand for PrEP has been growing in Vietnam significantly. With only 6 months of implementation, we achieved the PrEP target for almost for the whole year of fiscal year 19. Next slide nha. Nga ơi.
Can you hear me?
Yeah.
Hello? Yeah. Can you hear me?
Yeah.
Sorry, can you hear me? Okay. So, yeah, with increasing worry relating to COVID-19 in March, we began to reduce the private clinic footfalls from clients and then structuring a private clinic that offer PrEP, healthy market, and partner work quickly to modify service delivery to enable to continue PrEP services. In this presentation, we will focus mostly on this private clinic since public clinics were able to remain open, although at reduced capacity during lockdown, but were overwhelmed and not able to take on virtual service and home delivery. The COVID-19 virtual PrEP service flow for new enrollment started with online risk screening and individual contacting with the clinic via app or phone. They were then gather a blood-based HIV self-testing and tested together with the clinic healthcare workers online. And in case HIV negative, they will carry a 3-month supply of PrEP. The same HIV self-testing process will follow for the month check-in. And then quality refill and HIV test also be made quarterly. Next. Yeah. Here is an example, an online promotion that trigger client engagement with a doctor at Chilling Clinic. That is one private clinic, and mailing the HIV self-test kit. The private clinic and clients strongly endorse the use of virtual tool during lockdown and want to see this continue post-lockdown. Next. Yeah. Now for some data, Tour Vietnam started reacting to COVID-19 in January and had its first case in February. PrEP enrollment followed a normal pattern until later February. Here you can see weekly enrollment starting first week of January to last week of April. In January, we have a typical increase in new PrEP clients just before Tet festivity. And and then new enrollment dropped off as usual. But then towards the end of February, beginning of March, we can see another increase in new PrEP enrollee, a pre-COVID-19 lockdown surge, and then steep decline during lockdown through March with a slight pickup in new clients towards the end of April when lockdown begin to ease. What is important here is that new PrEP enrollment occurred throughout lockdown, that there was still demand for PrEP, that this clinic were able to respond that need. Next, please. Yeah. Here you can see that from January to April during COVID-19 period, the majority of enrollment was among MSM and then HIV negative partner of those newly HIV diagnosed transgender women, as well as people who injected drug and female sex workers. Next, please. Next, please. Yeah, comparing PrEP new enrollment, we see that there were much greater enrollment through the private sector as compared to last fiscal year. This may in part be due to the challenge faced by public clinics during the lockdown. Next, please. Yeah, as we look at the monthly early PrEP continuation among those that started in December, January, and were seeking the monthly refill, we identify that a lower than usual return in public clinics, which is normal, is 80s. For private clinics, they were able to carry PrEP drug to clients, but the public clinics were not. We know that some clients fear needing to physically go to public clinic, and that travel also prohibited during lockdown. So we are following up with this client to see if the discontinuation is true or they want to restart PrEP. Next, please. Yeah. Please.
Yeah. So moving forward, applying lesson learned from COVID-19, we are moving toward a vision where there is a unified digital platform that enable a number of functions all in one and that are linked together and make care easier for both clients and clinicians. We also offer home-based lab services, which are already available in urban areas of Vietnam, and self-sampling for STI were acceptable for clients for both private and public clinics. So last but not least, we would like to thank to great leadership from Vietnam Ministry of Health, to PrEP clinics and KPCBO, and USAID for flexibility and creativity during COVID-19 and beyond. The next slide, please. And that over. Thank you.
Thank you very much and welcome everyone. Here in Kenya, we have also gone digital using phone to reach our AGYW. Next, please. DREAMS is embedded in the Eswatini project in the 4 high burden counties of Kisumu, Homa Bay, Migori, and for the next 5 years up to 2022, we shall be providing interventions, including for adolescent girls and young women. Next, please. So before COVID-19, the DREAMS project was not implementing any digital modes, utilizing phones for service provision. And generally, we were providing services at the safe spaces where PrEP may be provided to girls individually and in their groups. Next, please. But with COVID-19, there has been, of course, limited access to the safe spaces, and we've had to come up with several measures, to try and continue provision of essential services, including PrEP. One of which is home delivery of services, where AGYW work, AGYW is adolescent girls and young women, work with their mentors to schedule delivery of services at home. We've also developed what we call temporary services, temporary safe spaces. And for this particular meeting, we've created what we call virtual safe spaces, where girls may be able to essentially reach and get information and services in a place where they are not inhibited. And we use text messages, calls, WhatsApp, video, etc., etc. Now, to facilitate this next, we first did a round to kind of look at what is the phone access of all our AGYW. Next, please. And in this review, we noticed that we have an average of 76% of all our adolescent girls and young women who have access to phones. Majority of them are the older cohort who actually own their phones, and ownership of the phone is particularly critical because of matters of confidentiality, safety, etc., etc. And so you notice here that at least on average of 76%, the older cohort does have access to phones, giving us therefore the opportunity to be able to provide them services in that context. Having understood this, we went ahead, next slide please, to develop parameters in which we are able to provide interventions via virtual safe spaces. And therefore, each of the wards that we work in 50 wards, was able to create their own virtual safe spaces in terms of WhatsApp for those who have smartphones. And here, AGYW can confidentially communicate with their mentors and service providers. I should say here that apart from the AGYW, the membership of these groups includes community health volunteers, mentors, and healthcare providers. And the communication that goes on in these forums allows for individual girls to essentially facilitate appointments and schedule service uptake and receive their PrEP. And also we do share lots of resources in a soft copy manner with all the AGYW from reputable sources. Next, please. And therefore, in the course of this, you may be able to see on your left that we are able via virtual safe spaces to provide continued capacity building on knowledge about PrEP. And on your right, you may see that we are able to engage each other in conversations. And you should see there, I want to highlight, for example, that talks of signs and symptoms. That was a conversation on STIs. But you notice a girl there asking, is it advisable to take PrEP when you are in a distance relationship? Another one, can PrEP be shared? So one of the things we are looking at and appreciating on this digital sense is that we are able to harvest AGYW issues and deal with them as such. So in the next one, next please, we therefore have a kind of outline of how we go about enrolling girls into PrEP and providing continued support for adherence and retention. So via online outreach, of course, the discussions on PrEP, PrEP education elicit requests from AGYW, who then work with their mentors and service providers on matters with regard to enrolling on PrEP. Now, using the Kenya Rapid Assessment Screening Tool, which can be done at the community level, the mentor and the CHV are able to do a quick assessment and then facilitate all this still via phone for a visit at the convenience of the AGYW to a clinician. The project does facilitate this, and the clinician reviews the AGYW using the standards as provided in our national guidelines. Once the girl has been initiated, the project continues ongoing follow-up, which again is facilitated via virtual methods of reaching out to the girls. Whereas we may do PrEP-specific check-ins on a monthly and quarterly basis, we do engage with these girls continuously within the week because they also do receive other DREAMS interventions. And finally, based on their post 1 month period, we facilitate the refills that they need to have in a manner appropriate to them. So again, working through funds, we should be able to determine whether the AGYW requires to have the PrEP delivered at their homes, come to the safe space, or to the health facility. Now, the next slide shows us the trend in which this adoption of virtual safe spaces has allowed us to maintain PrEP provision to AGYW. Next slide, please. And you will notice that at the beginning of the financial year in October, when we were doing our enrollment, we had low numbers of actual AGYW, and therefore PrEP was low. But in February, we did hit our peak because we had already enrolled quite a number of adolescent girls and young women. And then there is the post-COVID restrictions, which in Kenya basically starts around March 15th. But you do notice that these interventions, creative ones that we've put in place, including virtual safe spaces, allow us to sustain enrollment of AGYW on PrEP with, for the next 1.5 months, March 15th to April 30th, we were able to get over 90 girls enrolled. Next, please. At the same time, also, we do PrEP refills, absolutely useful for us for the continuation of PrEP, and of course, reaching out to the girls through funds, etc., etc. And out of that, then we do schedule uptake, of which we've had roughly 40% of them come for the services at the safe spaces, others at home, and also at the health facility. I should indicate here that at the health facility, it's a matter of scheduling that particular engagement with the requisite health facilities. So we've done this for quite a while, and I am particularly impressed that adapting virtual safe spaces and using the opportunities of funds, we are able to sustain, keep girls on PrEP, initiate them on PrEP, and continue providing them with follow-on services. Next, please. The government of Kenya has appreciated part of PAT's work, and we appreciate that the government also does run virtual platforms for this engagement. Thank you very much. I would like to thank all the partners that we do work with. Asanteni sana from Kisumu, Kenya. Thank you.
Thank you very much. And now we're going to go on to hear from the EPIC and linkages team. So I'll turn this over to Ben.
Thank you, Kristen. My name is Ben Eveslage. I'm a technical advisor for online HIV services at FHI 360, working mainly with the EPIC and linkages global HIV projects and several bilateral HIV projects. So I'll take us through this next session on going online with PrEP service delivery. So we'll have two presentations, including online PrEP refills and virtual case management in Eswatini from Laura, and PrEP Telehealth and Express services in Thailand from Tana. Next slide. So this session is focused a bit more on the how-to of virtual PrEP service delivery. I'm really pleased to announce that today's co-hosted webinar is also the first part of a larger 5-part webinar series, and you can see each of the topics and registration links here. I'll go ahead and paste into our chat a link to each pre-registration link, And I'll also paste a link to our public WhatsApp group chat where we discuss all things related to taking HIV services online. So there you have in the chat the different links. You might need to copy and paste the link into a browser in order to access those. To align with the objective of learning and demonstrating the how-to aspect, I asked our two presenters to share in their presentation more details on how they went about taking PrEP services online in terms of processes, challenges, and next steps. Next slide. So before we move into the presentations, I wanted to highlight several contextual factors that will impact how programs consider online and virtual platforms for PrEP service delivery. In terms of ethical and privacy concerns, it's also very important to consider the safety for clients to interact with an online PrEP campaign and to use various online apps or even phone calls to discuss PrEP needs and request services and also receive case management services. In terms of sustainability, this is going to become a major question that's now being asked when we're moving to virtual platforms. For instance, if this can be sustained in the long run. As mobile phone use and internet continues to increase globally, it's very important to use this time during the COVID-19 pandemic to institutionalize these new responses using virtual and online platforms for continued use post-lockdown. So this will help HIV programs to align themselves to deliver services to the mobile generation after COVID-19. In terms of low connectivity settings, online platforms cannot be the only solution. It's also important to offer virtual channels that are more accessible, such as voice calling and SMS, and working with people that also don't have their own mobile phone, but might have a friend or a family member that do have a mobile phone. So I believe some of our presenters will give some diverse examples that will help address some of these contextual factors. So we'll go to the next slide and I'll hand it over to Laura for her presentation, Online PrEP Refills and Virtual Case Management in Eswatini. Laura.
Thank you, and afternoon and good morning, everybody. Next slide, please. The presentation that I'll go over is going to cover basic background for context, and then I'll also make sure to outline our approaches and then review results and provide discussion points on what we plan to do next to continue and expand the current interventions that we have started. Next. And next. To help provide context, I want to share just relevant background specific to Eswatini. The COVID-19 pandemic coincided with the launch of our trueeswatini.com site, which is our going online approach. We shifted to virtual and online methods for generating demand for PrEP for both initiations and refills. And we moved all of our case management for PrEP to telemedicine from both the community outreach worker side as well as through our clinical side as well. Next. Within Eswatini, we do have certain limitations to what we can and can't do in country. All community-based testing is restricted due to COVID-19. Home delivery is not approved by the ministry based on overarching sustainability and logistical constraints. Nurse assistants are able to support refills, but not expert clients or equivalent cadre. And outreach workers cannot collect PrEP refill due to HIV testing requirements. And we only have the Aura Quick HIV self-testing in Eswatini. Next slide. And next. This slide overall shows the approach for case management that we now implement for PrEP. The start of this is for the outreach worker to line list client contacts info, and they follow up via the phone or WhatsApp to conduct risk assessments. And we link to a trueeswatini.com site to book for PrEP. In some instances, we use a refer a friend tool on the True Eswatini site for clients that we've reached prior and a lot have approved and consented to receive SMSs. And we also have the outreach workers follow up on all clients that set an appointment prior to the appointment time. The first step is for those that have booked to access the community centers. Right now, we're able to provide PrEP services during COVID for initiation. And in some instances, if they're not able to come to the KP-focused community centers, we do arrange home visits with the provision of initiating on PrEP if they're confirmed negative. While these home visits are not standard based on the MOH guidance, as noted previously, we are allowed to do them under the MOH in certain cases. The second step is for the clients to return for their 1-month visit, and they are provided up to 3 months refill. Outreach workers, again, support updates prior to the appointment, and similar for step 3, and for future refills, we provide reminders prior to. And we are at this point looking to expand to include pickups as part of our community distribution points that are being linked to the decentralized drug distribution interventions that have started in the country as a response to COVID-19. And as linkages, we are providing support to that. All of our follow-ups are now done virtually by the outreach workers, and we have one focused linkage case manager. They also use a newly introduced weekly tracking sheet for both ART and PrEP. So that way we're able to track and record and look at data on a weekly basis. We also have expanded to provide virtual psychosocial counseling that is also booked through the Going Online website, Eswatini, for anybody that does need it. Next slide, please. And then click as there's an animation. The video that's, oh, no, sorry, go back. We need to start the animation. I think, yeah, okay, perfect. Sorry. Right now, the video is going to show how PrEP support is done to support the continuation of PrEP during COVID-19. 1 second. All right, it might not be able to run right now, but hopefully it will show up as I explain what we have been doing. We issued a Facebook ads that link people to Chat for PrEP access for non-linkages clients. The appointment booking is done, which we're trying to have show through the video, but it's done through the Eswatini site where people click on, they're able to ask questions, and then they're guided to a link where they're able to then get the hours that are available. Our hours are constantly changing right now just based on lockdown constraints. Clients identified online are then accepted at the community center using a visitor refill approach. That is so the clients can return to their home facility post-COVID-19 versus formerly transferring clinics. We have a number of people here in Eswatini that have been moving around just because they've gone back to their family homes, and so they aren't even close to their current clinics. The outreach workers track weekly the clients that are eligible for the treatment refills, and those that don't want to access PrEP at their home facility are linked to the site to book an appointment at the community center. And also, again, if we are not able to address existing barriers for any refills, we do home refills if required. Next slide, please. And next. This slide shows the initial trends for HIV services that we are seeing through this Eswatini site. And overall, what we have noted is that through the online platform, we have a really high arrival rate. It's overall still small volume, but numbers overall for Eswatini are low volume due to our small population size. But these numbers are a drop from around 500 clients that we used to see weekly for clinical services through our routine services. The online virtual is a very new method of service access, and it's also not the only way, as people still do phone calls and have discussions via WhatsApp and talk about different times that are available at the clinics. On this slide, the red line that is at the bottom is the overall case finding. We are currently retroactively reporting these test results as FHI just took over at providing the clinical services in the 2 community centers during COVID-19. And we are working with the KP-led CBO that oversees our Going Online site. We do provide outreach workers. We find that this provides outreach workers with something to create demand around. It provides talking points to make concrete actions from peer-led sessions done virtually or through phone calls. And it gives them something to link to access PrEP. We are seeing initial higher uptake of PrEP and ART and case finding, which we will review in subsequent slides. Next. This chart shows that clients that are eligible for PrEP refills and those that have accessed those refills as tracked through our outreach workers. April 2020 was really the first full month in which the outreach workers followed up with clients virtually to support PrEP initiation and refills. As you can see by the slide, we have a strong rate for uptake of refills in April at 75%, but we do see a drop in May down to 54 with data only through May 24th. What we do know is that one of the weeks in May had only 9%, dropping the overall average. Our outreach workers are still looking into reasons for this so we can address it. The outreach workers are reminded of the confidentiality when conducting follow-ups and making calls, including thinking about where they're making calls, and any notes and data captured in hard copy as they are just writing down the notes from the discussions, they are kept in locked bags. Next slide, please. This slide captures overall PrEP trends since it was introduced at the community level for key populations here in Eswatini. What we generally do see is the uptake of PrEP contributed to 22% of all clients identified as negative from July 2019 through March of this year. Current PrEP uptake for April and May is at 29%. It's not a huge jump, but it is an increase during COVID-19. And I think it shows a lot of potential for more as people become more comfortable with the new norm that we're all experiencing. Virtual PrEP mobilization through the True Eswatini and the online reservation app allows for improved targeting of those most at risk accessing the services of the community center, which has, I think, contributed a lot to what we're seeing. We also route clients to the True Eswatini site through Facebook, Instagram, and through WhatsApp message groups to help increase demand with the risk assessment on site supporting refined targeting for those that are most at risk. Next slide, please. So what we're looking to do in terms of expanding case management on their True Eswatini site to support PrEP is really push to book all clients through the website. One, it helps avoid double booking. It allows us to manage and limit client flow. It also reduces wait time at the clinics. And it also allows us to adjust clinic hours based on demand. We can increase hours, we can reduce it, et cetera, as needed. We're also looking to use the True Eswatini site to help roll out decentralized drug distribution for PrEP, targeting our key populations, where we can then track the clients booked at the various distribution sites, and we can report uptake and the results of their visits in a more timely fashion. Next, please. Currently, just based on COVID, we are at 2 current sites where we used to probably do 50 outreaches all over the country a month. We want to start expanding these refill sites, and we want to use the virtual demand creation and online booking to really increase access to PrEP, as well as making sure we enable the continuity and refills. And as noted earlier, we just started more of the going online and as well as a virtual demand creation for PrEP starting in April. And so we want to start reviewing it to see how the performance has been and see how we can strengthen demand creation for PrEP refills and other services as well. Next. Thank you.
Thank you, Laura. There are some questions coming in under the Q&A box as well as the open chat, so you can go ahead and look at those. Next, we'll be having Tanat from Thailand presenting on PrEP, telehealth, and express services. Tanat, take it away.
Thank you very much, Ben. And good evening from Thailand. Today I'll be talking about telehealth and express services implemented at our community-based clinics with technical assistance from the Institute of HIV Research and Innovation, or IHRI. So just a brief distinction between the two terms. Telehealth refers to any service that is done virtually. So there's no physical contact between the client and providers. Express service is something that I really like to describe as a Starbucks drive-through. You'll still have to be physically present at the clinic, but there's an express lane available for you. Next slide. So today I'll be talking about the overview of our sexual express services, our PrEP telehealth, how to effectively use PrEP during these times, our express services, and then we'll conclude. Next slide. To mitigate the risk of acquiring COVID-19, measures such as social distancing, physical distancing were placed. Well, this involves moving everything that can be done virtually into an online platform. So physical contact can be reduced to a bare minimum. So only through butt collection will there be physical contact. We also implemented in-clinic self-sampling for STIs and also notification of results via mobile phones. Next slide. So this is a summary of our telehealth flow for current PrEP users. So eligible clients are those who are currently on PrEP and have demonstrated good previous adherence and retention. Clients can reserve online and a provider will contact them assessing their eligibility criteria. If they're eligible, a referral letter will be sent out for clients to get their blood tested near their homes. We have so many clients who live all over Thailand, and some provinces implemented travel bans across province. So it makes it impossible for clients to travel into the clinic or into the city to get their HIV testing. So clients can get their blood tested at remote clinics near their homes, and they can send the results back via messaging applications and get reimbursed for them. And then we'll send out PrEP delivery to refill for another 3 months. And then we'll have a virtual meeting on through social media applications to follow up on them to see if they're okay with the medications. Next slide. I think Kim has briefly mentioned about the shift from daily to on-demand PrEP. So it's something that we found a problem as well, because many countries also implemented travel bans, including China and India, in which we import raw materials and generic drugs. So we had an issue last month where there was a disruption in the supply chain management, making our PrEP inventory low. So we reached out to clients to teach them how to effectively use PrEP during this period. Many of our clients are men of sex with men, and they're on daily PrEP, and they don't find themselves being at risk during physical distancing. So if they're on daily PrEP and not having that much sexual activity, that might not reflect onto effective use. So we try to reach out to our clients to shift to event-driven PrEP during these periods, and they can change back to daily PrEP when they're at continuous risk. So we call this effective use of PrEP. Next slide. So I'll talk a little bit about our express services. Next slide. So we were lucky that we implemented these services before the COVID-19 outbreak, but the rationale behind this service was to tailor services based on our clients' needs. So many of our clients in the past have to take time off of work, maybe half a day or a full day, just to get their PrEP refilled. And many have been on PrEP for quite a while, so they have a good knowledge on how effective this PrEP is and how important adherence is. And they don't want to listen to the same pre-counseling every time they're in the clinic. So this affects their willingness to receive service or even being retained in care. So the express route is implemented to serve that notion. Next slide. So this slide shows the current flow that we have for new cases and follow-up cases. You can see that the routine flow are quite long. It can be more than 1 hour on a normal day, but can be up to 2 to 3 hours if the clinic is tight. So if a client walks in and wants to get PrEP, they'll be screened for tuberculosis and will be registered. They'll undergo a pre-counseling, getting their blood drawn, waiting for the results, and have a post-counseling and answer a PrEP questionnaire in order to get PrEP. And the same is for current PrEP users as well. So it's a long time that they have to take off work in order to get PrEP. Next slide. So Express moves everything into an online platform. So the client can register online and select the service that they want. They can register online as well. And then they can perform all the questionnaires and their consent online, also tuberculosis screening. once they reach the clinic, they can just confirm their appointment, have a very brief pre-counseling and get their PrEP refilled, get their next appointment, and just go to the phlebotomy room and then just go home. They can choose to receive the results in whichever way they want. So it could be SMS or email or through Line. Line is a very popular social media messaging application in Thailand. Next slide. So since implementation in June 2019, we had 2,024 clients who were eligible, and most of them preferred to have the results notified by Line. And if you look at the right side of the graph, you can see that there's an increasing trend in the number of Express clients in the past months due to COVID-19, which also reflects that Express service is quite important during this new normal times. Next slide. So what about the new normal in the Asia Pacific? I think we need a more differentiated service delivery models, task shifting from doctors and nurses to lay providers and to the people. We need self-sampling in clinic or even at home, self-testing, and home pharmacy or pharmacy-based ART and PrEP refills. For ART, we need multi-month scripting, and we need to implement effective use of PrEP. Next slide. So how do we do it? The key primary step in implementing new services is to ask the providers, to talk to the providers. Are they motivated? What did they feel about introducing these new services? Because some providers might feel that they're already overworked with the amount of work burden they have at the clinic, and introducing these new services, they might think that, you know, it's too much for them. But you have to explain to them that implementing these express and telehealth service will actually decrease the client volume in the clinic, and they will have more time to look after clients who need more care. And it's also very important to engage all relevant stakeholders since the beginning to have that agreed on the service flows suitable for each clinic, because each clinic operates differently. And putting that on paper, so developing a standard operating procedures after that. And one thing that our providers really like is to have a dry run of the real service. Having this dry run before actual implementation of the service, you can actually identify the gaps and the challenges during this dry run for when it's ready to go, then the providers feel confident of implementing these new services. Next slide. That's it. Thank you very much.
Thank you so much for these excellent presentations, and we have had a very active chat and Q&A in which a number of questions have been answered along the way, but I'm not sure that everyone has seen those as they are listening to the presentation. So I'm wondering if perhaps we could first go to the PATH team and to Kim and reflect on some of the questions that you've seen come through the chat and share them live, share the responses live.
Yeah, okay. I'm scrolling up to see if I can find some of those questions. I think, you know, there was just one question related to STI services in Vietnam. And so we responded saying that yes, STI screening is available at initiation for PrEP. And that also there's screening that happens every 6 months. So that's for syphilis, gonorrhea, and chlamydia. There's also the introduction of a pooled sampling approach to reduce the cost for molecular testing for gonorrhea and chlamydia. There was a question as well around the cost of PrEP. And so we responded saying that PEPFAR supported PrEP services are free, but there are also different models. There's a commercial model that's available, and the pricing is titrated really depending on the clinic that's offering that service. And what else?
I don't know if you addressed this, but there were a number of questions around access to phones and just wanting to know how do you reach those who don't have access to phones?
Yeah, so phone coverage is extremely high in Vietnam, and Tom mentioned a survey that was done in 2015 with key populations where we found very high coverage of feature phones and smartphones. And significant amount of use of social media, and particularly Facebook. So there's quite a lot of access in Vietnam. I think there was also that question, maybe it was more targeted towards the Kenya team. So Mariang might have responded that there are issues. There was that analysis that he presented of different age bands and access to personal access to a phone, and that there's a titrated model that's put in place to reach adolescent girls and young women who don't have a phone, using a mobile safe space service that's put in place based on the rules and regulations around mobility with COVID-19. But thus far, they've been able to get out a number of mobile services with universal masking to make sure that all clients are in contact with a provider.
Thanks for that, Kim. And I think there were questions answered in the chat about this from Madiane, but around confidentiality, particularly for adolescent girls and young women. I don't know if anyone wants to reflect on that with the virtual services. And I think it relates to key pops as well, but in terms of going virtual, are there additional considerations around the confidentiality?
Madiang, do you want to talk specifically about Kenya? And then I'm sure all of the speakers will want to weigh in.
Thank you very much for that. And I responded to, I think, two members. Now, one of the things is the functions of the general portal is communication and ensuring that AGYW have the information. And secondly, we do provide links and directories of all service providers. So there are kind of rules that you set and encourage for those who want services to individually reach out to the folks. Now, secondly, in terms of all those confidentiality, it's a matter of how we do deal with the information that we do get in the forums, especially text, etc., etc. So in Kenya, there is a function of calling back anybody who does not have airtime. We call it please call me. So AGYW are encouraged to hit the please call me, and we've facilitated community health workers, mentors, and service providers with airtime, so they are able to call back the individual and provide services. Finally, there was a question on violence, and somebody was asking whether we have witnessed any violence in the families from parents and or partners. What we have witnessed is that the choice of where to take the service once we have completed the phone methods is informed by the confidence that the individual has in either the parents or the partner. So those who accept home-based delivery have total confidence, and we've not had issue with that. Those who have issues in terms of, they say, I have never informed my partner that I take PrEP, then those come to the safe spaces and healthcare centers. So we do protect them from that particular violence. Thank you very much, and over to you.
Thank you very much, Marianne. There is a question that came through via email, so I just want to mention it. It's a bit tangential, but still related. It talks about the perception that because PrEP is an antiviral, because it works against HIV, that perhaps it would work against COVID. And are any of your groups experiencing challenges with myths and misconceptions related to using PrEP to prevent COVID, which it's of course not indicated for?
This is Ben of Eswatini. I'll just mention that this has been anticipated in a lot of the risk communication strategies for not only PrEP, but COVID throughout our HIV programs. And so there's a KP and COVID messaging matrix or messaging guidance that includes messages that can be sent to clients to clarify some of these issues. And some of the risks that we're seeing is that there's more demand for PrEP for people that aren't looking to use it for HIV prevention and maybe for COVID prevention, even though that is not proven. And so it can lead to people selling your drugs, and even worse in the case of people that are living with HIV. The same situation applies there. So what I can do is I can share a link to this messaging guidance and ask if Laura or to not have any experience with this in their programs.
Yeah, and similarly, we've been doing the same with risk communication around ARVs on COVID-19 and PrEP.
In Eswatini, we do promote obviously discussions on COVID related to different HIV services as well, but we do follow the guidelines that were created. So that way we have very strict messaging, and we make sure we're sharing all the right information and answering the different questions that arise. But I've not heard that as a issue at this point.
For me, I've in Thailand. I mean, I'm actually. It's actually a really widespread misconception about PrEP and COVID, and also other ARVs and COVID as well. So as a result, to mitigate these misconceptions, we also developed some communication materials, and also we did a Facebook Live to talk specifically about PrEP and COVID and HIV and COVID. And we also made some communication materials to distribute around our social media circles to address this as well.
Great,
and Tom,
you.
do you want to talk a little bit about what's being done in Vietnam related to messaging on HIV and COVID?
Yeah. So especially at the beginning of the COVID, so there was a misunderstanding about using ARV for COVID-19 treatment. So our team, we have a community task force team, and we collect and translate and also refine number of information to correct this kind of misunderstanding and misinterpretation, and to share with TP about that information, and also respond to the question through the hotline. So it was happened at the beginning of the COVID, but now I think information was already spread, and the less kind of this type of information spread among key populations. Yeah.
Thank you. There was another question also from my colleague with Discover Health, and he's put this in the chat now, that he also sent by email. So this is about how countries are handling behavior change and perception around female sex workers and the demand for PrEP. He writes particularly with these models of drug distribution that seem to be client-oriented and numbers-driven. But in the email, there was more of a question around, are there any things that your programs are doing to not just provide PrEP for sex workers, but also to do behavior change that also promotes using a condom? I think that's where the question is going.
I'll just respond for Vietnam, and Tom, please weigh in if you want to. But I think for all of our HIV prevention programming, there's information and counseling related to options that are available to whether that individual be a sex worker or someone else, and really for them then to decide what tools they want to use. And so condoms are widely available in our programs, and we're ensuring that PrEP is also accessible, and that clients can determine when and where they want to use a condom versus PrEP. Thanks.
Thanks, Kim. I wonder if we could go over.
Sorry.
Oh, go ahead.
Just wanted to add to Kim about PrEP and condoms. Well, it's a large debate, and with all prevention programs, we always advocated for condom use, but we also have to be kind of realistic about what's happening, because a lot of the times, due to many occupational or situational factors, a condom might not always be available. And we need other prevention options for those who are at risk to prevent themselves from HIV.
Well said, thank you. I want to go over to the EPIC and linkages team. I know there were a number of questions in the chat that you answered directly, and I wondered if there are any that you would like to just reflect on for the larger group live.
Laura, are there any questions in the chat you think are particularly interesting you want to review?
Hopefully I didn't miss any. I mean, I think the biggest one is, I mean, the main question I saw relating to Eswatini, unless I missed them, because there's a lot of introduction chats, was just about PrEP availability, and it's free in Eswatini. So that was the only one that I saw relevant to Eswatini specifically. But I hope I didn't miss a question.
And Tanat, were there any other very interesting questions you think you would like to respond live to?
I see one question on, are there any evidence in terms of data PrEP has really worked in terms of reducing new cases of HIV infections? I think there's quite a lot of information out there in trials about PrEP effectiveness, and also data in the real world where countries which has adopted widespread of PrEP are seeing a drastic reduction in HIV incidence, such as London or San Francisco.
Tanat, I have a question that was mentioned in the chat, and I think this is important in the context of virtual PrEP service delivery, is around self-sampling for STIs, which might become important in the quarterly screening process that many clients go through when they're on PrEP. So this was a question by Harsh in India. Tanat, were you doing self-sampling for STIs, and how was it done if you were?
Right, that's a very great question. We've just started to implement self-testing at our Tangerine clinic, which is a clinic for transgender women. And we've developed communication materials prior to launching this implementation. So pamphlets and videos or instructions for clients on how to self-collect oropharyngeal or anal or neovaginal swabs themselves. And also the next phase that we're going to do is we're going to implement a self-sample collection room with a well-lit room with mirrors in the next phase. But it's just a pilot phase, and we have a couple, 10 to 15 clients collecting through self-sampling.
Okay, so to clarify, it's in-facility self-sample, not delivery or home self-sample.
It's a point where we want to reach there, but haven't reached yet. So it's now in clinic
Okay.
STI samplings.
Okay, great. And I have a question for both, and this also applies to any of the panelists about regarding client data security and privacy concerns. Just wanting to hear what clients themselves are saying to your programs as you begin to offer virtual solutions. What are the concerns that clients are bringing up? And if you have any solutions for those, just to hear what really are the concerns from clients. Laura or Tanat?
I mean, sorry, this is Laura from Eswatini. So where we have seen the concerns, which I think was also pointed out here, is just as portions of the demand creation, just, using WhatsApp groups, et cetera. And we're trying to do more of like link group discussions, but people are afraid to join based on that people will be able to see who they are in those discussions. So we're also trying to see, we do know some people have been using Facebook in different ways. So trying to see if we can move some of the virtual demand creation aspects of it to Facebook itself. I think in terms of some of like the booking and the access to the Eswatini and those different sites, I've generally seen on the one-on-one chats, people have been very open with needs and the issues that they have and their concerns with the different counselors that are helping. So I think that that's at least been positive. But I also know that some suggestions that we have for some of the online, there's some pushback just based on the people's concerns about being exposed of being a key population through some of the virtual platforms themselves. But so far we're just focusing on what we can and where people are comfortable. The same thing with access to phones. I think only 70% of our outreach workers have phones, but we're just focusing on what is working and trying to really just move that forward and making sure that we just keep reminding people about confidentiality and what happens. And we make sure we have strong moderators as well in the different discussions that we have.
Thanks, Laura. So I have a couple other questions that have come through. One is that question around continuation, and I did see this in an earlier question as well. The more recent question from Humphrey is specifically around how do you measure continuation in the context of going between daily PrEP and event-driven PrEP. But there was also just a question of how do you measure continuation in the context of the virtual delivery of PrEP. Does anyone want to reflect on those?
Yeah, so for PrEP continuation, we are tracking that in person and virtually the similar way. So that's basically when the client comes back for their refill or requests their refill and it gets sent to them. That's effectively how we're tracking continuation, is that refill. And then with ED PrEP and individuals who might be transitioning between daily oral and event-driven PrEP, again, there's communication that's happening between the client and the clinician when they might want to switch. Some clients are starting off with ED PrEP, some are switching between the two. And so our data forms are just basically just tracking where the client is during their check-in, if they're moving from one to the other or continuing to stay with event-driven PrEP versus daily oral. Yeah. Nga, feel free to add in if there's anything to add there. Thanks.
If there's nothing to add, then I'm going to go over to Robin Akel from USAID. She has a question. Go ahead, Robin.
Thanks, Christine, and hi, everybody. These were some excellent presentations, and I'm really excited to see all of the innovation happening. I'm curious to know, Laura mentioned during her presentation that there were some pretty strict, rules or policies right now because of COVID, just limiting movement, but you were able to negotiate some home delivery. And it sounds like you're also negotiating being able to move around to create community pickup points. I'm wondering how you accomplish that. I think a lot of other countries and programs and teams are facing similar issues and trying to figure out how to best negotiate being able to incorporate some movement of their teams to facilitate community drop-off and pickup points for both for ART and for PrEP. So I'm curious how, Laura, how you all did that, but also maybe if other of the speakers have encountered something similar, if they could also share that. Thanks.
Thanks, Robin. So in Eswatini, we worked with I think there's two parts. We worked with the Ministry of Health to get us determined as an essential service. And we got a letter from the Principal Secretary of the Ministry of Health saying that, as FHI, we are doing A, B, and C. And so we were able to get that for all the CBOs that we work with. And then we issued just letters saying that this person was traveling for an essential service. We also did find, because when we kind of fluctuate in terms of the restrictions on travel. So we do know that some people also used SMSs. So they would just say this person is coming for a health service. And most of the time that would allow getting through to police checkpoints and also just phone calls. Sometimes people would just call like one of the people at the health facility, etc. if the person was coming to one of our areas for a pickup, and they would just talk to the police and they'd say, oh, this person is coming for A, B, and C. So there were still some hiccups, but those are some of the interaction and the interventions that we did to get around the transport restriction.
Does anyone else want to comment on that? No, okay. So we're going to move to our sort of final comments and close. I just want to turn to folks on the panel if you have any final questions for each other or any final comments you'd like to make.
This is Oloch Madiang from Kenya. And let me say this, that in this period, we are really trying out stuff and learning from them, taking and using opportunities that are provided by all the systems, including applications for communication, such stuff as WhatsApp, Instagram, Facebook, etc., etc. So what I've observed today, those questions on confidentiality, etc., etc., are challenges that currently we are living with and trying to learn how we may be able to, going forward, work together with applications developers to create even more flexible forums and portals that we may be able to use. Secondly, or even these virtual safe spaces and utilization of telephonic methods, their success works with continued involvement of other opportunities that we do have, provision of airtime, data, etc., etc. Thank you very much. I appreciate every conversation that occurred. Over to you.
This is Kim. I would add that COVID-19 has required us to very rapidly shift the approaches that we're using for PrEP service delivery and other healthcare. And I think there's been a lot of very rapid learnings about how we can adapt services in a way that are, further meeting the needs of the clients that we serve. So I think my big takeaway and hope is that we can normalize some of these approaches, like virtual contact with clients for initiating PrEP and PrEP follow-up, utilizing home delivery of ARVs, home-based lab sampling, and just other ways to make it easier to be on PrEP. So I hope that we can encode these moving forward as part of national approaches. And just one last request for that collection of models on community-based or differentiated PrEP services. If you haven't already submitted your work, please do so, and we'll paste the link in the chat. Thank you.
Excellent. Thank you, Kim. Any other comments?
This is Ben Slash from FHI 360. Just want to thank you, Christine, and the rest of the team for the effort on this webinar. It was amazing, the number of participants, and I think our team are happy to, our team members are happy to respond to chats afterwards. And if there's any questions as well, you can join our WhatsApp group, which was posted in the chat, and we can address questions there too.
Great, thank you. And Aubrey, if you'll go to the next slide, that is a good, or continue after that. That's a good follow-on, that we will actually be posting not just this webinar, but also the slides and a resource sheet that includes key questions and answers from the chat, as well as these websites that have been shared today. And those will all be sent out within the next week to everyone who registered. We also have a brief survey today, so I'm sorry I'm not going according to the slides here. We also have a brief survey we would appreciate your taking at the end of this session, and I just want to really give a shout out to our excellent speakers from the PATH and EPIC linkages team. I so appreciate your presentations, and also for your forward thinking and leading us into a future that hopefully will eradicate COVID, but allow us to continue to be innovative and creative with our PrEP delivery. So thank you all very much, and wish you all a great day and evening. And please do respond to the poll, which is up on your screen right now. Thank you. And we will keep the line open for a few moments as folks respond to the poll.